Hi everyone. Today I'll be doing a short run through on the MRCP PACES station for Ethics and Communication station. We'll be going through some general matters, looking at ethical principles, and subsequently going through common topics. In terms of general matters, so this is a 20-minute station with a 5-minute preparation time prior to the station itself. 14 minutes are spent on the patient's encounter, 1 minute for reflection, and 5 minutes for discussion. So apart from preparing for the actual patient encounter, the candidate should also prepare for being able to hold a discussion about ethical principles. So usually the questions will encircle around what are the ethical principles involved, how do they come to conflict or weigh against each other, and where are the dilemmas faced. So it will be good practice to also go through the thought process involved. The second tip is focusing on the task at hand. So it is important to always look at what specifically the task is and to execute the task accordingly rather than shaping the discussion according to one's own agenda. In terms of preparation, firstly would be to familiarize oneself with the common topics, which we'll be going through later on. I find the second one also pretty helpful in terms of preparing and practicing certain stock phrases for difficult situations that one would anticipate that may occur quite frequently. We'll go through some of them too. And the third has already been mentioned, to learn how to structure your discussion around ethical principles. In terms of ethical principles, I think most of us are familiar with this from medical school. So we just go through them quickly. In terms of autonomy, the idea is that each individual has the right to self-determination. However, there may be instances where autonomy may not be able to be preserved. In instances where, let's say, one does not have capacity, so there may be a need for some form of surrogate autonomy. And in instances where there is conflict with, let's say, public health, then in instances with, let's say, someone who may be at risk for harming others, that's where autonomy may have to take a second seat. Beneficence is about doing what's in the patient's best interest. Confidentiality is about the trust between the doctor and the patient. Non-maleficence is about not rendering harm to patients. Equitable care and distributive justice looks at allocation of resources. Professionalism is about one's conduct in a professional manner with patients. And truth-telling and candor talks about the patient's right to have information about their condition and treatment options that are available. So this concept of negligence is one that is important. Negligence occurs in the following instance: when there is first and foremost a duty of care, where there is a breach of duty and subsequent harm resulting from that breach. So the old paradigm of Boehm's test has usually applied to diagnosis and treatment, where a doctor is sort of held to the standards of what is agreed upon by the medical community. So as long as there is internal consistency and logic, that is deemed adequate. However, with since 2015, with the landmark case of the Montgomery trial, there has been a paradigm shift away from simply internal consistency amidst the medical community, but with the focus to the patient. So the three criteria are: firstly, whether relevant and material information was withheld from the patient; secondly, whether the doctor was in possession of this information; and thirdly, was the doctor justified in withholding the information from the patient. So this basically was born out of a case where a patient sued because of a complication that she deemed resulted from a paucity of information that was disclosed to her, and the court ruled in favor of her. Hence, it's important to familiarize oneself with this paradigm shift and the requisites of the Montgomery principles. So next we'll be going through common topics: breaking bad news, retroviral disease, genetic counselling, brain stem death and organ donation, end-of-life matters, medical errors or complications, communication with colleagues, consent taking, capacity assessment, and counselling about different conditions. So breaking bad news, we use the spikes model that can be actually carried across many and most counseling stations, but of course, sometimes it has to be tweaked and adjusted accordingly. So we just briefly go through. S stands for setting. So one normally begins with a greeting, seeking whether or not the patient wants, or rather the patient or family member want anyone else around, and finding a suitable environment. The second about perception is about finding out what the patient already understands, so that one would be able to pitch the conversation at an appropriate level. The point about invitation in the context of breaking bad news is about firing warning shots rather than just delivering a heavy blow by just telling the news directly. So examples include, unfortunately, I do not have good news. Are you okay with me proceeding to tell you about it? And knowledge is about knowledge provision. And what's important is to do so in a manner that is jargon-free. It's also helpful to signpost along the way and to always check back on the patient to see whether he or she is following. It's also important to pay attention to the patient's response. If they are not responding, they are keeping quiet, it's usually worthwhile taking some time to pause and allowing the patient to collect himself or herself. E stands for empathy, so empathic statements are useful. And S stands for summary, strategy, strategizing, and sending off. So this is where we close the conversation, talk about follow-up steps, and what's going to happen next. So I'm sure we are quite familiar with the different kinds of conditions, maybe cancer, serious condition, and it may be weaved into other scenarios later on. Just a point for sudden death, it might be worthwhile pointing out that the patient may be considered a coroner's case. Okay, next we talk about retroviral disease. This is quite a favorite in the station 4 scenario. So there can be various forms of this. It can be consent taking for testing, let's say someone who is at high risk, or it could be breaking diagnosis of a test that was done. And in this context, it is important to find out the circumstances surrounding the test. Was it a routine screening? Was it because the patient was already at high risk? Was it a condition that may suggest underlying retroviral or opportunistic infection manifestations? And concerns about spouse, concerns about work are also not infrequent. Caution when using spikes, especially for the S component. For retroviral disease, one may not want to ask if, let's say, would you like someone else around, especially if he or she doesn't know that you're going to be talking about breaking news about this diagnosis. So some general tips. I think the first is to demyth the difference between HIV and AIDS. AIDS is sort of the endpoint where there is clinical damage and manifestation of the HIV virus being present in the body, and HIV infection merely suggests that there is the presence of the virus in the body, but the immune system has not yet been compromised. Whereas in AIDS, there is a compromise in the immune system resulting in opportunistic infections. I think the second thing that is important to highlight is the treatability of the condition, and to liken HIV to many chronic diseases where with good treatment, good control and follow-up, oftentimes patients can lead fairly normal lives. And the third point is that HIV is a reportable disease. So this is where sometimes candidates struggle, and when faced with a situation of like, whether I need to tell my spouse, etc. I think it's I'm not sure whether detaching is the right word, but it's worthwhile putting it up there that, okay, this is a reportable disease. The Ministry of Health will contact any sexual partners because of the public health considerations. As a doctor, you would not be the one going to the spouse's door and house and knocking on her door and telling her. And so I think that's important to communicate, because it's not like you are there telling the patient, hey, I'm going to tell on you, rat on you kind of thing. But yeah, I think in terms of coaxing the patient to tell the spouse, there are a few things that can be done. Firstly, given the MOH will inform the spouse to suggest that it might be better that the spouse hears from the patient himself. Earlier diagnosis, resulting in earlier treatment, and basically going back to suggesting that, if the patient loves the spouse, cares for the spouse, this would be in the spouse's best interest. And thirdly, also offering to help with the conversation if, let's say, he or she is amenable to it. There are a few things surrounding HIV and pregnancy. I'll leave it to you to read, but it may be something that may have to go into the counselling, especially if this is a female patient in the reproductive age or is expecting some medication side effects with teratogenicity and obstetric implications such as consideration for C-section and the need for post-exposure prophylaxis. So when it comes to common questions, what if I don't tell my wife? So as mentioned, focus on the wife's well-being. There might also be implications on, let's say, children. If let's say the kids are young and this, we don't know how long this has been going on for. And yeah, as mentioned, the contact tracing will be carried out. It may be better if the patient, if the wife hears from the patient himself. When it comes to intercourse advice, generally advise against intercourse in this period of time, especially prior treatment, and basically the implications of informed consent. Okay, next we talk about genetic counselling. So genetic counselling is something that we don't see that commonly in our local practice, but it does feature fairly commonly in the PACES Station 4 exam. So I think in any genetic counselling case, it's important to find out the purpose and the desire behind this genetic testing. Why is it that the patient wants to go for genetic testing? So then one needs to also have an idea of the background. So that it's not a full history taking, but to get an idea of like, is it symptoms that are prompting this test? What's the family structure like? Are there people in the family with a similar disease, etc.? So then it comes to the explanation bit. So I think the two key things are the limitations and the implications. So genetic testing is not a golden bullet. There are problems with it. You may get false positives, false negatives, and even indeterminate results. Even if the result comes back positive or with a seemingly clear answer of, let's say, having the gene, it doesn't answer questions of whether one would definitely get the disease, when one will get the disease, whether the disease will be severe. And yeah, so I think these are things that would have to be laid on the table for one to consider that it's not as straightforward and not as binary as, like, hey, I test positive, hence I'll have the disease at a certain time. The second thing is implications. Implications, I think of it in terms of implications to self, implications to family, and perhaps even implications to the unborn offspring if, let's say, family planning has not been completed yet. To self, there's insurance implications, anxiety, uncertainty. Sometimes it's the question of whether I want to know some of these things when there may not be any full certainty, even when information is rendered. To offspring, yeah, so issues about whether or not they may acquire disease, issues about pre-implantation genetics, etc. To family members, given that if one tests positive, there may be other implications to the rest of the family. So when it comes to genetic testing, oftentimes it is most effectively done when other family members are involved, with the reason being that genetic testing is normally most effective when it is targeted rather than broad-based testing. Broad-based testing has problems of increased cost, variants of unknown significance, and that can become problematic. I think in any discussion, it is important to always tell the patient that this is not a decision that has to be rushed into. One can take time to decide, to discuss, and to refer the genetics team or to a geneticist to guide further in terms of further decision making. Yeah, so in terms of whether I'm obliged to tell my family, the answer is usually no, but there may be implications, and given the nature of genetic disorders, you would encourage them to tell them. So this next few points summarizes the common autosomal dominant, autosomal recessive disorders, X-linked, and variable inheritance patterns. You can spend some time looking through and to think through how you want to remember them. Okay, next we talk about brainstem death and organ donation. So I think the first thing is to communicate that brainstem death is actually tantamount to death, and this is important because it has to be done with a certain amount of finesse and compassion, of course. But if this is not properly conveyed, oftentimes one may get stuck in the scenario, especially if it's a multi-layered scenario where one has to communicate brainstem death, talk about organ donation, etc. it would be difficult to get to the second and third parts of it if, let's say, it is not categorically communicated in no uncertain terms that the patient is actually dead. So that's the first point. The second is one can attempt to transit to the topic of organ donation by inquiring about patient's nature, whether he or she was someone who would like to help others. But once again, this can only be done when there is some degree of acceptance that indeed the patient is dead, because there is no way that one can move on to a conversation about organ donation if, let's say, there is still uncertainty or hope that the patient might be alive and there might be a miracle, etc. Explaining the process that the organs will be removed by a surgical team, will be closed down in a dignified manner, and the body will return to the family. So these are some of the legal pieces of information that is important to know. So HOTA is an opt-out scheme applicable to all Singaporeans 21 years old and above. Organs implicated are the cornea, the heart, the liver, and the kidneys. Any other organ for any other purpose will fall under the MTERA Act, where it's an opt-in system where anyone can pledge an organ for treatment, education, research, and it can even be done by the family members of the deceased. And brainstem death is certified by 2 doctors who are not involved in the care of the patient nor in the transplant proceedings. So when it comes to the next topic of end of life matters, this can flesh out in various things. It could be about extent of care, things like artificial alimentation, etc. I think there are a few principles. The first is about the idea about care decisions and seeking input from family. So we know that oftentimes when it comes to life-sustaining measures, it is at the end of the day a medical decision. But in our local context, this is always done with the collective input from family, where we look at the medical status, the functional status, the patient's wishes, and to some degree the family's wishes, which in the ideal circumstance should be a surrogate to the patient's wishes. In instances where, let's say, there is futility of medical treatment, it is important for one to explain about the patient's condition, the possibility for or the impending demise, the irreversibility of the condition. So oftentimes, like when we talk about things like sending patients down to the ICU, doing very heroic measures, the idea is that it may seem to prolong life, but the question is whether or not there's something underlying that we can reverse and can change. And this moves on to the goals of care, right? This ties in with the patient's expressed or surrogate's wishes, with the patient's current medical status and anticipated disease trajectory. So it is always helpful to link specific interventions to goals, and when we are able to point out the discrepancy between what we are doing and the goals, that's where we may be able to make some headway in terms of certain discussions. So when we move on to the discussion about like in our minds care withdrawal or rationalizing of some of the heroic measures, it is not about, the focus is not about withdrawing treatment, but instead effecting appropriate treatment that would be serving the patient's best interests and keeping alignment with goals of care at that point in time. And I think it's useful to look at things from this framework and to try to paint this picture about asking ourselves and bring the family on board in terms of what we are hoping to do for the patient. And it's always helpful to reiterate that you walk alongside the family and the patient on this journey. So the next bit is about some specific questions with some stock phrases that you may consider. So when we talk about, IV fluids feeding in a patient who is actively dying, one may say that, patients in this state often do not perceive thirst or hunger, just like how we may not be hungry or thirsty when we are feeling very ill. And because of this, we address this idea of them, feeling very hungry and uncomfortable. Then, and a corollary is about starving to death, right? So one can explain that loss of appetite is part and parcel of the natural progression or trajectory of the underlying disease, while the lack of nutrition does contribute to the process of death. It is unlikely that, number one, this will be the main thing that drives the cause of death, and it is unlikely that the patient will explain or experience hunger, rather. We will be monitoring closely for symptoms and signs of hunger, and we can always initiate comfort feeding. And so bringing in the idea that, maybe sometimes it's about the taste, the experience that matters more in this current situation. The third point is about when there is conflict with resuscitation status or extent of care. This can be tricky, and one of the tips that I learned is that a second opinion is always something that can be offered in a manner that is, of course, not defensive, and in a manner that still keeps the patient's best interest, and expression that one is still hoping to do the best for patient at the center of things. So one can say that, your views are definitely valued and heard. However, as a doctor looking after your dad, I would be unable to provide treatment that I feel will be bringing him more harm than good. But I'll be happy to arrange a second opinion consult for a different perspective. Is that all right with you? Okay, so just taking a step back, looking at the systems, different structures that we have in place, this is just a quick refresher. So advanced care planning is a voluntary discussion. It is about patients' preferences when it comes to end-of-life care. This is documented as a guide for the instance when someone becomes incapacitated, but it is not something that is legally binding. But actually, in practice, this is really the go-to document that we often find ourselves using, because it is accessible, because it is practical, and it's something that we advocate for our patients. The next is an advanced medical directive. This is actually a legal document against artificial life support in the context of, number one, a terminal illness, yeah, it has to be a terminal illness, and the patient has to lose capacity. But it is something that is administratively difficult to retrieve, because the medical team will need to check with the registrar of advanced medical directives only when the patient is deemed terminally ill and incapacitated to make the decision. And oftentimes, this doesn't really come to fruition. So I would say that the practical sense ACP is oftentimes more helpful. And the lasting power of attorney is once again something. It's a legal apparatus that empowers the donee to make decisions on behalf of an individual has lost capacity, and this can pertain to matters of medical care, matters of the estate, etc. Next, we shift gears to talk about medical errors, complications, or adverse outcomes or events. So I think the first thing is to take a step back and to look at the situation, to ask ourselves, where did things go wrong, and whether or not there is fault. If there is fault, an apology should be rendered sincerely and and in no uncertain means. Um, However, if let's say it's a situation where it's let's say an adverse outcome that wasn't due to an error or something that was done wrong, I think it would be, or let's say there are things that it is uncertain, the circumstances are still uncertain at that point in time, pending an investigation. It might be worthwhile being a bit cautious about the way the apology is rendered. Um, when one says, "I'm sorry for this," one may then be attributing blame to something that, let's say, is not clear at this point in time, and hence one can instead express feeling sorry for the situation that it's in. I'm sorry that things turned out this way. I'm sorry that that I'm unable to bring you better news, etc. I think it's important also to allow the patient or relative to vent and rant. Give it some time. Instead of butting in and always trying to push one's agenda, it's important to let them have their airtime, and to hear what exactly they are upset and angry about. And thereafter, one can then identify and empathize and validate the reasons for anger. Apologize once again if it is appropriate to, and attempt to steer the conversation to the subsequent management of the patient after, like we go into things like, let's say, we'll be doing a thorough investigation, root cause analysis, etc. But always recenter and rehome in on how we want to do our best for the patient. The caution is about being defensive, about blaming your colleagues, so don't throw your colleagues under the bus. At the same time, also, I think we can find appropriate means of escalation if things get out of hand. So, patients relations department, etc. When they ask about things like, I demand compensation, I want my treatment to be free. Some of these decisions will be beyond your call, and it's important for you to acknowledge it and to then basically refer it to the appropriate channels. So mitigating measures as mentioned, and some of the specific questions specifically about demanding a name or details of a colleague. So one can go through this, can attempt to address this by saying that to apologize that you're not in the capacity to divulge this piece of information, and that you recognize that, let's say, if it is indeed a mistake, that a serious mistake has taken place, and the medical team looking after your mom will collectively take responsibility for what happened, and then subsequently also offer that a thorough investigation will be carried out, and the patient's relations officer will get back again, once again, to, if let's say they are really demanding some form of explanation or account as to what happened. So communication with a colleague usually takes place in the context of someone with misconduct, poor performance. It is important. I think two things that are important. First is to find out things from the colleague's point of view, and second is to show concern and to assure the colleague that you are on his side and you want to help him along. So show concern, find out any difficulties, and offer to help. Reflect objectively and find out how the colleague feels about it, and to strategize how to improve. Once again, the caution is about being judgmental from the outset, but at the same time also one has to be cautious about minimizing any misbehavior if indeed present. Consent taking, most of us are familiar with this explanation of the procedure, treatment, the indication, implications of not doing the treatment. Alternatives is important, and risk explanation also has to be carried out. And this ties in nicely with the second bit about capacity assessment. So the principles are that generally every patient has capacity until proven otherwise. Just because one has, let's say, mild dementia, or even in the context of delirium, doesn't necessarily mean that the person does not have capacity, because capacity has to be taken into context of that particular decision that is being made. So I may not have the capacity to make a very, very complex decision, but I may have the capacity to decide on something simpler, for example. Hence, the onus is always on the medical team to make the assessment. And if formal assessment is required, then only practitioners who have undergone formal training and whose names are registered under the Office of Public Guardian can perform the assessment. So usually we'll refer to psychiatry. The steps involved in capacity evaluation are assessing for comprehension. So what is relayed can be comprehended, subsequently retained, and then processed and weighed up, and finally recommunicated back in a processed fashion to the practitioner. So this, I think this is the last or second last slide where we talk about explaining diagnosis of condition. So this is once again quite common and would involve medical knowledge and content. So find out about about understanding and concerns first to frame the discussion. Explain the disease and diagnosis without medical jargon. Explain treatment. You can break it down to categories and signposts. Explain monitoring, complications. And then contextualize it into some of the other things, like does it affect offspring, does it affect work, insurance, and driving. I think these are things that are important to have at the back of your mind for all station 4 cases, because they may or may not be relevant, and hence it's important to think about it actively rather than reactively. And you can provide other information about support groups or other relevant resources. So this slide is about driving. You can read around the driving regulations. And yep, I think we've come to the end of the sharing. Hope you found it useful.